Care homes are never in the press really for good news. They're always in the press for bad news. And I've spent the last 12 years trying to assiduously avoid being on the front cover of the Daily Mail. And one of the things that's quite clear to me is the more I've looked at care home residents, the more I realise we don't understand. And I'll just give you a couple of examples. Many years ago I did a little study, not published, it wasn't significant enough, but it was looking at what happened to people's attitudes when they went into care homes. And what I found was they became less depressed over a 2 or 3 month period, but they became more anxious. And I couldn't quite understand that. So I went to ask them why this was, and I interviewed about 30 people. And the consistent story I got was they were less depressed because they were more comfortable than they'd been either at hospital or home, but they were anxious because they didn't know what was going to happen next, and they weren't being navigated. And recently we've just completed our 4th major census of care home residents, and for the last few years I've been working internationally, and I've been looking after 35,000 beds spread across the UK, Australia, New Zealand and Spain. And one of the fascinating things we found using an outcome measure called How Are You is over a period of time people become more satisfied with being in a care home, even though they become more disabled. Now I think that's not a commonly understood phenomenon. And so I want to start by giving you some understanding of care homes as I see them. Of course, in the UK, we have this great history of the workhouses and the terror of the workhouses. When I worked in North Somerset, I looked after an old workhouse, and I used to have to do domiciliary visits to persuade people to come into the workhouse. And there's a very wonderful website called workhouse.org, and you can go and find the names of people that were in workhouses in the turn of the century and what have you. And it becomes quite interesting to see some of the names that I had difficulty persuading to come in, very localised names. Whole families were in the workhouse for long periods of time when they fell on hard times. So we have all that baggage, and we have a social model of care for people in care homes, and yet actually today almost exclusively people end up in care homes by virtue of ill health and frailty. So we still look at care home residents almost as their residents, giving them a status rather than the patient with dementia, the patient with stroke. That's what we want. The reality is over the last 20 or 30 years there has been a consistent offsetting with a reduction of care homes as a place of residence because of inadequate housing or poverty, or it might return in the near future, and an escalation of use of care homes for people, particularly with cognitive impairment and frailty. And in fact, now in our care homes internationally, around 70% of people are in the care home specifically because they've got cognitive impairment and therefore can't survive outside. Now in the UK, we have got a lot of care home beds, and it's little understood that for every bed in the NHS, be it paediatric, obstetric, gynecological, cancer, there are more than 3 care home beds. So there is a huge dependence in the ecosystem of health and care in the UK on care homes. If the care home sector catches a cold, the NHS is likely to catch pneumonia. I still don't think that's fully understood. And part of the problem we've got is this huge sector doesn't have a home in the Department of Health. So you have social care, where they see 80% of their adult social care budget going to care homes, which severely undermines the ability of social care to be innovative in supporting people in their own homes and other forms of community care. And you have the NHS that very often sees a care home bed as a cheap option to a hospital bed. Very, very difficult. Neither party is really looking strategically at how those beds work and how they fit in to the landscape of health and care. And so for us now at Bupa, over the last few years in the UK, something like 70 to 75% of our beds are entirely reliant on funding by local authorities. Around 15% of our beds are under contract to the NHS, and the remainder, relatively small number, about 15-20%, self-pay. The NHS beds are roughly split between providing intermediate care of various sorts and fully funded long-term care. And the most interesting thing over the last few years for me is firstly the increased turnover of those intermediate care beds and the reduction of the commissioning of those beds, so that what we're seeing now is a reduction of occupancy in our homes because there are gaps between each discharge and admission, and when you accumulate those, you've effectively got a reduction of occupancy. But you've got much more churn, much more throughput. So whereas typically if you go back 10, 15 years, people came in for several years to a care home, they're now coming in, if they're certainly on intermediate care, for a week or two. And if it's end of life care, we have people coming in and dying within 2 or 3 days, almost as hospice care. All that means that the social model is increasingly strained when looking at how care homes work. And the regulation and the understanding of dignity is very much up for grabs and very unclear in many ways. We have a bit of a perfect storm happening now. It is very difficult now, with that intensity of activity on publicly funded care home beds, to make a reasonable return. If you're in the private sector, if you're a charity, you have to make a return. It's not like a public service. Public service has to be managed very well financially, but there is no safety net, and there is a slow but steady trickle of small to medium-sized care operators now becoming financially unviable. For those of us who have the luxury of working with big, well-funded organisations who are still developing care, almost all the developments that are being made now are for private self-pay care. What I'm really saying to you is over the next 5 to 10 years, as a lot of the care home stock in the UK becomes worn out, there is going to be another crisis in care. And we will see at some point hospitals starting to silt up. So we all know that prevention and stopping people becoming frail has to be the goal, and maintaining health and well-being and avoiding people needing care. But it is actually very important to understand how older people decline and die. And one of the most impressive studies I've ever read is that by Lynn and Anderson from the States, looking at how older people use Medicare in the run-up to death. And this is not just care home residents, this is a whole sort of population, big population study. And they found that something like 20% of people died from conditions such as cancer, conditions where there was a lot of treatment and then there was a clear watershed to a palliative care and a death in a relatively short time. About 20% of people died from long-term conditions such as chronic obstructive pulmonary disease, where there are typical progressions and deteriorations and acute exacerbations, and in those acute exacerbations, death is more likely to occur. 20% died from sudden deaths, be they coronary heart disease or an accident, but 40%, and this is the crucial thing, 40% died from what the Americans quaintly call progressive dwindling. And progressive dwindling is growing because it is the long-term neurological conditions, the dementias, the Parkinson's disease, and all those sort of conditions that cumulatively currently form the core of the care home population in the UK and indeed internationally. And so I'm going to suggest to you that if we want to be really dignified about the way we care about older people, we need to start focusing very much on those sort of conditions and the way people dwindle in them. And just as the management of cancer was transformed by the advent of palliative care, we need to start public awareness of what the trajectory is of those conditions. Because one thing's for sure, uncertainty is one of the big problems confronting families when they put someone into care. And if I go back to my original comments about that anxiety of what happens next, there's a lack of understanding, and it's simply not good enough to say, you're just old and that's where you're going. So when hospital says, there's nothing more we can do for you, you need to go to a care home, it is very right, but it is somewhat wrong. And when the care homes say, when you come in, what we'd like to do is look at advanced care planning and plan for end-of-life care. That's all very well, but the average length of stay in a care home now in the UK for someone being admitted with dementia is typically around 20 months. Well, you're not dying for 20 months. There is a gap there that isn't filled by a constructed, purposeful approach to medicine. So I want to rethink a bit about how we go about medicine for this population in care homes. When I was trained, medicine was all about diagnosis and treatment, and as long as you said in an examination that the goal of your endeavours was to treat symptoms and avoid complications, that's obviously morphed now into a much more preventative approach, and well-being is what we seek to maintain. We also now, in the last few years, have focused greatly on end-of-life care. But what we haven't done is looked at people who have got illnesses that are starting to slip beyond treatment, but which are not actively killing them. And I'm going to suggest to you we need to create almost a new approach to medicine. I'm calling, for the want of a better term, formative medicine. And I'll give you some examples of what I actually mean by formative medicine. Just clinical vignettes. I used to have a clinical interest in Parkinson's disease, and like a lot of doctors working with patients with Parkinson's disease, you would push treatment really very hard to try and keep people in their homes with their families. So you would push treatment to try and maintain someone's mobility, so an elderly spouse could do assisted toileting and so on and so forth. And you get to a point where it just wasn't working. It just wasn't working, and the patient went into a care home. And this was a watershed. No different to that occurs in many ways for someone who's had cancer treatment and all of a sudden the treatment is not working and you need to change tack to a palliative stance. And the thing is that if you're in a care facility where you can have full care in terms of assisted transfers and so on and so forth, actually you can tone the treatment down. And funnily enough, the patient becomes more lucid rather than hallucinatory, and they get a better quality of life. That is the sort of thing I mean by a formative approach to conditions.